Welcome to Conversations in Lung Cancer Research, a TOGA podcast where we discuss the latest breakthroughs in lung cancer research and treatment for Australia and New Zealand. My name is Alex Davis and I'm a medical oncologist at the Northern Sydney Cancer Centre. The Thoracic Oncology Group of Australasia acknowledges the traditional custodians of the land on which we live and work. We pay our respects to the elders, past, present and emerging. We also extend that respect to all indigenous people.
TOGA also acknowledges Māori as tangata whenua of Aotearoa, New Zealand, and as treaty partners with the Crown as agreed in Te Tiriti o Waitangi.
I'm going to open with a karakia. Whakataka te hau ki te uru. Whakataka te hau ki te tonga, kia mā kina ki uta, kia mā taratara ki tai, e hi aki ana te atakura, he tio, he huka, he hauhu, tihei mauri ora.
In today's episode, we're exploring lung cancer in New Zealand, so I can say kia ora. Today on the show, we're excited to have a multinational panel, which is essential for this topic. You might have just heard someone lead us into a karakia, which is Dr. Laird Cameron, and he is a medical oncologist at Te Puriri or Te Ora, Auckland, and is a senior lecturer at the University of Auckland. I also have with me today Dr. Annie Wong, who is a consultant medical oncologist at Wellington Blood and Cancer Centre and is a senior lecturer at the University of Otago, Wellington and the University of Auckland. And I'd like to welcome them both to TOGA's Conversation in Lung Cancer Research podcast.
Thanks, Alice. Kia ora.
Kia ora.
Kia ora. So, lung cancer remains the leading cause of cancer-related death in New Zealand and Australia, with significant disparities in outcome, particularly for Māori population. Despite advances in treatments, late-stage diagnosis and limited access to screening and delays in funding for new therapies continue to impact thoracic cancer patients in New Zealand. New Zealand does not yet have a national lung cancer screening program and does not have a number of systemic therapies available. Research and clinical trials play a crucial role in shaping the future of lung cancer care, with increasing collaboration between Australia and New Zealand institutions being critical, where we can look to leverage our clinician skills and expertise and improve outcomes across our region. So the goal of this podcast is to explore the current state of lung cancer care and research in New Zealand and highlight the challenges and potential strategies for improvement. So I might just kick off with some basic questions. What led you both to specialise in lung cancer treatment? Annie?
Well, for me, I think it was more by serendipity rather than intent. So I actually did a melanoma PhD at Peter Mac and came back to Wellington, New Zealand, my hometown, and I was posted in one of our more regional clinics, and there was a lot of people with lung cancer there. And so I think it was mainly to serve the community, and the more I did it, the more I fell in love with it. I think for us, knowing the people, making that connection and being embedded in the community is a real priority for us. And I think once I got involved in that, I was more involved in the lung cancer community through our national collaborations as well as TOGA. And then from there, I built on the work that I'm doing with ESMO, doing more collaborations within the Asia-Pacific regions, looking at lung cancer policy. So I've really fell into it, but I've loved every bit of it.
Well, that's great to hear.
So my choice to specialise in lung cancer was quite different. I chose early. I was a first-year advanced trainee in medical oncology in Wellington back in 2012, I think it was. That's when I decided my whole career was going to be treating lung cancer, and it was not a popular choice. People told me I was crazy. I was quite sick of the best supportive care discussions. We've got nothing effective for you, or you're not fit enough for chemo, and that's sort of pretty much the end of it. But we did have, a little bit of a hint at precision science. Back then, there were first-generation EGFR inhibitors around, and immunotherapy wasn't a thing for lung cancer at that point. And there were rumours of targeting ALK. So applied for Peter Mac and pretty much sold myself hard out to Ben Solomon to become a lung cancer fellow. And I told them then I'm not doing any other tumour stream. So I kind of made my choice early, and pleased I did, because if you look at the last decade, the acceleration and the speed of science and therefore treatment options has been amazing. And now I've got trainees in the same year that I was, more than 10 years ago, fighting to come in and learn more about lung cancer. And it's because it's got so much interest in types of treatment and all the progress we've made. So I chose early, and I'm pleased I did.
Yeah, that's great. I mean, look, it's obviously an incredibly rapidly developing field over the last decade. And I guess with you both having spent some time in Australia, what difference do you see in the patient populations for people with lung cancer in New Zealand compared to Australia?
So the patient population in New Zealand, our lung cancer patients, or looking at New Zealand as a whole, we're only 5.5 million for the whole country as our total population. We have a high rate of lung cancer in our indigenous Māori, and Māori who get lung cancer have a higher death rate. So although Māori are 17% of the total population, they have 3 times higher rate of getting a lung cancer and the same 3 times higher rate of mortality once they have lung cancer, regardless of stage. So essentially, we have disparities by our indigenous ethnicity compared to others. We have a wide range of ethnicities. We have a large component of Pacific Islanders in our New Zealand population, and also Asian populations, which is relevant, in the settings such as EGFR, especially up where I work in Auckland. We have a lot of EGFR positive lung cancer cases coming through with a high proportion of Asian in our community. Yeah, so we get just over 2,500 new cases of lung cancer a year in New Zealand. And we have just over 1,800 deaths per year. And just as you said in the intro, Alex, it's the leading cause of cancer death. It's well above all of the other types of cancer. I think that's a bit of an international trend, and New Zealand's no different in that respect. So that translates to about 450 new referrals per year to my centre in Auckland. So in terms of volume of patients, we're on par with most of the major cancer centres, I think. Although you've got a lot more centres in bigger cities, I think as a centre and the volume that we treat, we're quite comparable, at least in Auckland. We do know there's disparities by socioeconomic status, and also there is variation across our country by geography and available centres as to access and pathways to diagnosis and treatment, even though we're a small country.
And I guess that gets onto my next question and more with, lung cancer care pathways. I mean, Annie, how does that work in New Zealand? And, from your time in Australia and your experience, in international collaborations, how does that differ?
Yeah, so in New Zealand, most lung cancer is diagnosed at the advanced stage because we don't have a screening program. Patients usually present to their general practitioner, but a lot of patients who are more disadvantaged and can't access the traditional pathways would present to the emergency department with advanced disease. And then we do have access to the standard diagnostic workup here, so that's very good. Circulating tumour DNA is a relatively new thing here, but we've just started incorporating that into our diagnostic process. But all of the standard imaging, access to respiratory interventions, all of that's publicly funded. I think that's a strong point in New Zealand, is that we have universal health care, and everybody can access that. There are, challenges sometimes with funding of primary care, general practice, so that is something for the government to work on. And then in terms of the diagnostic service, there is some regional variation in terms of once we do the biomarker testing. So Auckland, where Laird works, he's got NGS set up there now, but that's not across New Zealand. Different labs are still doing different techniques. So that is something I think we need to work towards. In terms of treatments, that's quite different to Australia. I think Laird and I were reflecting before that at every international conference we'll have some Aussie friend come up to us and say, "What drugs have you got now?" Almost nothing. But I think that is something that New Zealand does struggle with. Our patients struggle to have access to a lot of lung cancer treatments. We do have a very strict regulatory approval process for our drug treatments, which is very good. And because of that universal healthcare, there's a limited budget to work with. I can give you some examples in terms of targeted therapy. We were sitting on first-generation EGFR inhibitors from 2010 right up until osimertinib was only approved this year, January, right, Laird?
That's right, yep, for osimertinib first or second line.
Yeah, and whereas some of the other targeted treatments, alectinib, that only came in 2019, and then more recently for treatments for ROS1. In terms of immunotherapy, I think that was a really case example that we were such an outlier compared to even among Asian countries where we would think of lower economic status. We for pembrolizumab for lung cancer, that had MedSafe safety approval from 2016 onwards. So that's very comparable to FDA, EMA. But in terms of reimbursement from publicly, that was only reimbursed in 2023. So there's a huge lag between MedSafe approval and then pharmac reimbursement for some therapies. And then, of note, we don't have any immunotherapy reimbursed for small cell lung cancer or mesothelioma. So there are real treatment access gaps here.
I guess with pharmac, my understanding is very much reimbursement is based off a model of, is this the greatest value spent for money for the nation as a whole? As our treatments get more sort of esoteric and smaller biomarker groups, do you see that being a challenge moving forward?
I guess I'll start off and Laird can pitch in at any time, but I think pharmac, they do a wonderful job of negotiating price. And then once it's approved, it's publicly available to patients with no gap. There's no cost share, right? Once it's approved, it's available. And then it also drives our healthcare delivery. So it drives the Ministry of Health to put in place resources into delivering that treatment, be it increasing the access to specialists or chair time in the day units. A lot of that starts from pharmac. I think its challenge is then, of course, with a limited budget, how do you best spend that money? And we have to have a really high bar in terms of ensuring that it has survival benefit, that it's got good quality of life benefit before that's approved. And so that can lead into real delays in terms of not getting approval, so drugs based on surrogate endpoints in trials. But once it is approved, I think the access is good. Yeah, what do you think, Liz?
I was just thinking about Alex's example of very small subgroups of lung cancer with a biomarker, an oncogene with a 1% frequency, where there's two parts to that. Because of how rigorous the New Zealand assessment of the evidence is, it's not impossible, but it's very hard to get funding if it's not a randomized phase 3 top level, level of evidence. And as we know, in the more rare tumours, there's a lot of phase 2 trials around gaining FDA approval, and that makes it more difficult. Having said that, we did get ROS inhibitors this year, and that was crizotinib came in June, and we're due to get entrectinib in December. And that's based on phase 2 data. So it isn't impossible, but it really slows down that assessment of evidence. The flip side is, of course, it's less patients needing the drug once it is funded. So when they do their back of the envelope, how much will this cost me? It's not going to be as much of a budget blowout, because there are less patients. It's a very specific requirement to target. I think it's just that we put into context of all types of cancer, and in fact, all medicines for all of the health system is what we're putting is what pharmac has to do. And the other thing is it's a fixed budget. There is a cap. The money's not there, it's not there. There's no push it up. And I'm not sure if PBS has that cap model or not, but we certainly do. And it's the often quoted reason for just not having drugs. I mean, it does vary a little bit when the wider government decides to give a cash injection, which to my observation seems to time with election years, but it's still a little bump up on the cap. It's not an open budget. Yeah,
I think obviously, as our populations expand and get older and more morbid and healthcare gets more expensive, it's a challenge for both countries.
Yeah.
And I guess, we can talk about drugs and access to drugs, but there's obviously something for our patients that can make a big difference, and that's lung cancer nurses? I mean, is that a model that's been brought out in New Zealand?
I mean, the short answer is yes. We've got an awesome lung cancer nurse workforce, specialist nurses, a program to try and support and increase nurse practitioners. I don't think we have enough, but there is a pathway. And I mean, in our team, the specialist nurses are the complete glue. They hold it all together. They're often the main first contact for patients from the community to reach in to get opinions and help from us. So yes, I think we actually do really well. The calibre and the inclusion in our everyday team of specialist nurses is very strong in New Zealand. Would you agree, Annie?
Oh, absolutely. I think it does vary a little bit by region about which centres have access to a lung cancer nurse specialist. Some of the centres, their nurse specialists will have to cover a lot of different tumour streams. And then we also have cancer navigators embedded in both in the community as well as the hospital system. So if someone's going through the diagnostic workup for lung cancer, they have that added support. Yeah.
Can I ask you, Alex, do you have, I can't remember in Australia, obviously you have a great nurse workforce that I've met before. Do you have a navigator type role where they are not trained nurses and is more about the pathway through a health system than it is about the oncology care? Is a navigation role strong there?
Different centres have different models. There's some that just employ purely lung cancer nurse, and they, part of their role is a navigator, just through the initial workup. Other centres just have a purely nurse role and a purely navigator role. 3 of the cancer centres I've worked at, it's very variable, and that's just within Greater Sydney and New South Wales. So I can't think of someone that had a purely navigator role, like a purely non-clinical role, but for the most part, it is, nurses who have some clinical experience, or a lot of clinical experience really, and but they navigate particularly through that initial first workup where there's so many things happening and it's easy for doctors and patients to get overwhelmed, and we just need, someone to guide us the way forward.
I wonder if one distinction from New Zealand is the Māori specific navigator and support services we have, which are focused on Māori for that, trying to bridge the way that our cancer services with Te Ao Māori and make it easier, basically. At our place, that group's called Awhinatia Te Tangata, and so any Māori patients being referred for any cancer, not just lung, we'll have a reach out and a contact, prior to the first appointment and, what do you need, how do we help you? So we have an indigenous focus as a subgroup within navigation services. And I think that's working well, at least from what I observe in my practice.
We have just recently, I think, I've worked with community navigators who are specific to Māori. They're based in the traditional marae, more built in around the Māori primary care providers. And so I think having that link between community base as well as hospital is really important too.
Yeah.
And I guess, Annie, for, the initial workup of lung cancer, how do you see rurality playing a role in patients who have a new diagnosis? They may live outside of or far away from a main tertiary centre and they need, 5 different tests done yesterday. What are some of the different models used to navigate that?
Yeah, I mean, it's a real challenge for across the country. But I guess maybe our distances are quite small compared to when we think about Australian distances. Say, for example, the regional areas that I cover down in the North Island, that would be about patients who are 2 hours away. But not to say that that's not a challenge, because they do have to come to a larger centre to get the specialist diagnostic workup through respiratory. They are offering more virtual clinics or using our MDT as a base. Well, when we have our multidisciplinary meeting, we do have different specialists from those regional areas dialing in and making sure their patients are being presented, had an MDM and discussion about what's the best pathway to get that diagnostic or treatment workup. And so I feel like we're connecting at least once a week to make sure that care is provided. Yeah. Laird, what do you guys do up there?
We're a bit more urban where I work, to be honest. It's not so much about distance or rurality for my Auckland region. Having said that, part of the northern region is Te Tai Tukaro, which is the Northland space where there are distances, especially right up in the far north. And they're reaching into a Whangarei hospital base, which is a few hours north of me. And they're introducing more strategies. They are setting up treatment ability in smaller regional hospitals and a bit of a satellite model out of Whangarei. But at the end of the day, right now, there's no radiation bunker up there, so they'd have to come all the way to Auckland. There are plans to get one in. In fact, I think it's going live next year, but don't quote me. I don't know the timeframes. So there are some services like a PET scan, radiation, and a surgeon that remain right down here in Auckland. And that's more than 2 hours travel if you're right up in far Northland. So it is a disparity. I think it's on the radar, especially with the Cancer Control Agency coming in, who have a bit of a mandate to try and look at equity by geography across our country, the whole postcode lottery piece. And so, yeah, it's got some attention. It exists. But in my everyday practice, it's very urban. So I don't have a lot to comment on in that myself.
I think for the South Island oncologists, it's a very big geography, right? That they have to cover a large area. They all tend to do regional clinics and try and supervise a lot of nurses. And actually, it is the cancer nurses in those areas that really hold the community and guide the local practitioners. Yeah.
As you mentioned, the virtual MDT attendance is excellent because the distance, in terms of decision making at least, the distance isn't the obstacle, right? So I think MDT discussions of thoracic cases is quite strong across the country. But when we do part 2 of this one day, we better get someone from the South Island to talk about it because they may have entirely different opinions. They have the widest geography from home centres.
Yeah, when I hear about people in Dunedin that have to head up to Christchurch for various things, it seems like a long way. There's a lot of mountains to go over. And I guess for lung cancer care, we need a lot of access to other services and testing. Do you ever find that, access to radiology, MRI, that can be challenging? Because I certainly know there's a lot of geographical variation in Australia about access to MRI, and sometimes, that does impact on care pathways and management decisions for patients.
I mean, maybe I could take that one in that not specific by modality so much, I don't experience, but just the overwhelmed radiology workforce in the whole country, and that's without lung cancer screening. The wait times to get your scan, even in a big centre, isn't too bad, but the sacrifice is the resource to report that scan. That's where we're having some delays. So radiology needs an injection of resource and workforce, I think, across the whole country, but wouldn't specify it down to certain types of scans. Yeah. That's my thought.
But same with pathology, right? In the lab, there's, they're just tinkering and on that edge of being able to diagnose a cancer and get the reports back within 2 weeks, which is what they all aim for. But it is a challenge.
I guess as, someone looking at New Zealand, one of the really appealing things is, CTDNA, which, you have in use and we would love to have access to in Australia and help guide our decision-making. How did that come about? I mean, what was the process for that to be enacted in New Zealand?
It was very nation specific and came along with osimertinib. So that's the bottom answer, is to find our T790M acquired mutation. We wanted more than biopsy. We wanted a liquid biopsy specifically to find it and then tick the box to have osimertinib after first line erlotinib or gefitinib. That's how it came about. It was a little niche space, and it's still niche. We don't have across the board CTDNA. We won't claim all of that, but the current funded program is an EGFR panel, not NGS, but it is clinically available, not reliant on access programs or clinical trial. And so it's an example in one space where we've got liquid biopsy option. And the other thing to say about liquid biopsy is that we don't tie our drugs to the method of the testing once we get funding. So I have no problems giving osimertinib for an EGFR detected by blood or by tissue. It doesn't matter. And I think that's a difference compared to Australia, where perhaps there's more restriction once you do get your drug on how you're allowed to use it. We wait longer, but have a bit more leeway for clinical decision making.
And also, I think because we're small, us as even as clinicians and our special interest group, the LOSIG, we have direct contact with the Pharmac team. And so when they do a drug approval, we actually have direct consultation with them as a group and talk about, well, some of the ways of practice, of implementing practice, is a bit more nimble in that way, I feel.
And I guess that leads on to my next question. What are the major strengths and weaknesses that we can learn in both Australia and New Zealand in lung cancer care to improve patient outcomes across both countries?
Well, of course, I'm going to start with the strengths of New Zealand. Quite aside from being the best country in the world, when we're narrowing it down to lung cancer, I think that we've already mentioned a few things. So our size gives us a really strong national clinical network and collaboration. And Annie mentioned the New Zealand Lung Oncology Special Interest Group. We have a WhatsApp where we can communicate instantly, discuss whatever's come out of a big overseas conference or make the whole country aware of an access program. Once one doctor here knows it, all lung cancer treating doctors who are members of LOSIG know it. So we're really connected, and that gives a clinician voice to feed back on things like the criteria used once we get a drug from Pharmac. So I think national collaboration, which might be just a feature of size, there's 5.5 million and Australia's a lot bigger and divided into states where we aren't. So I think that's a strength for us. We're nimble and connected. Another strength, equity. So we know that there is inequity, especially for our indigenous Māori, but we're aware of it, and at least in the clinical workforce, there is a willingness to do whatever we can to address inequity and have it out and spoken about and encourage whatever strategies we think can work in terms of, cultural safety and the way we deliver service. So I think being aware of our own inequities, not that we don't have them, I think that that's at least a starting point, and in that way is a strength for New Zealand. And, awesome researchers in Māori health space. We need to plug that too, to keep us updated on how we're going and where we're missing, where the gaps are and how we can do better. What else, Annie? What else? I wrote here that both countries are trying to head towards smoke-free, so that's a strength. And I think that we need to do everything we can learn off each other to keep driving that way. That's huge in the setting of lung cancer. Not that all lung cancers are caused by smoking, but becoming smoke-free is still a priority and should remain so. Yeah, and I talked before about less restriction once we get a drug. That's a bonus. So there's some strengths to lay out to start with.
Yeah, I think we actually have a single health system now for the country. We used to have district health boards within the different regions, and so we're trying to standardise to try and reduce that postcode lottery. The fact that we all have a national health identifier number is a strength in terms of data and research into that space, because I think we can, it sets us up on a really good platform to share data across the country. And lastly, I think some of the work that the Cancer Control Agency is doing in that space is good as well. That's trying to look at, we've set up this program called Act Now, which is looking at the different systemic treatments around the country. It's a start. We're trying to compare what regional variation there is, and then try and meet regularly to talk about standardising that across the country. And then if it's not deliverable in some settings, then asking the questions of why not, and how can we best support it.
And in terms of using, real world data or, clinical outcome data, is there, a homogenized system across the country to use that for lung cancer research?
We're trying. So the New Zealand Cancer Registry is the data set really that the government works on in the ministry. It has limitations. It doesn't have TNM staging data. It's based on a pathology diagnosis for a case to be entered into the registry. But the CanShare program, again, talking about Te Aotearoa, which is the Cancer Control Agency, I think that there's huge value in it, and Act Now was one program under that. That has the ability to really guide our care and drive research at a national level. It's still underway, but it's not there yet. It's not that I can right now jump on and see everything I want to from CanShare, but the work's begun. So I think that's a positive.
Well, that's great. And then how do partnerships like TOGA and clinical trials enhance research opportunities and improvements in patient care for lung cancer across both countries? Annie?
Well, I mean, the TOGA, Laird and I are both committed members of TOGA. We love being part of that community. I think it's a real strength that it's out of the research organisations in Australia, it's one of the few that recognise Australasia as a priority, that we're trying to include New Zealand in that group. I think Laird's got very good examples of participating in a lot of the TOGA studies, right?
Yeah, so even right back to NevoRad, we were lead recruiters here at Auckland on NevoRad back in the day. I've been an investigator on Dreamer. Currently, Oceanic is open. There's huge interest across all of New Zealand centres for Modern Lung, which is a trial sort of in workup, not launched yet, but that's in the chemoradiotherapy space. So I think really at the end of the day, groups like TOGA allow a platform to answer the research questions that are important to Australasian clinicians and patients. You know, it's that investigator-initiated space where I think the real strength and collaboration comes in. And actually all of those trials that I just mentioned meet that definition, that there was an important question that came from the care sector. Yeah, so I think it's hugely important. Also, it's let me maintain all my relationships. I hooked up in Peter Mac as a regular contact and extend those to new ones. So I think especially that regular face-to-face meeting, I'm a big fan of meeting people in person. And so the ASM, hugely valuable. And you can have ideas, and there's, of course, working groups and good pathways to develop a concept right through to a protocol. So I think you're asking the people who are complete TOGA converts, but I do see that it's a strength, especially in the research space, to open up opportunities for New Zealanders as part of a wider regional group. Yeah. Some studies don't need TOGA. So there's one I'm doing now, which is looking at optimizing immunotherapy specifically for Māori with advanced lung cancer. And I didn't take that to TOGA because it's a very New Zealand healthcare context, indigenous question. But looking forward to all my next ideas, because I like to have lots of ideas, they're going to be in the molecular space or database work. And so, you know, existing platforms like Aurora from TOGA, be great to collaborate. That'll be hugely helpful across the ditch as well as across Australia. So, yeah, I'm starting to rave a bit. TOGA's great.
I think it was as young investigators, it's a great platform to get our research ideas peer-reviewed before we launch into the space, especially with TOGA having, you know, a very mixed multidisciplinary input into it. I found it really helpful to go to the group and discuss our idea for our FAST study using CTDNA to hasten diagnosis of lung cancer. Sadly, you guys couldn't participate because you can't prescribe off it. But for us, it was really good to have that discussion to look at the study design and how we can actually make it happen. And, you know, it's up and running and well set up because of that.
Yeah, great. Or, you know, the TOGA Scientific Committee and certainly a great sounding board for new ideas and clinical trials. But for you both, as a lung cancer clinician, what is the next intervention or therapy which you consider to have, you know, the most impact for New Zealanders with lung cancer? Laird, I might start off with you.
My wish list. All right, I'll rank it. There's plenty on the list, of course. I think firstly, it's important that whatever we get, it reaches the people who need it the most. I don't want any intervention that's going to serve some New Zealanders only. So we just keep that on radar as we're trying to get hold of, standard treatments. Number one is lung cancer screening. It's a lot of work. You guys have it. It's on our radar. We don't have a time frame, but I think that will have huge impact across the board for mortality from lung cancer. So if we're looking about what would have impact in the space of lung cancer at a broader level, I think lung cancer screening is important. And, you know, as a medical oncologist, I'm not really knee deep in all of the implementation bit. I am involved in some research here in our region looking at models that serve Māori for when lung cancer screening comes. So it will come. It's going to be a matter of time and advocacy. Number two, perioperative immunotherapy for resectable non-small cell lung cancer. We have none. We want some. And my money's on neoadjuvant The Checkmate 816 protocol is before Pharmac, and New Zealand LOSEG have given its strong support and feedback on all of their questions in the context. That doesn't mean we've got a promised date of getting it, but it's a high priority. Number 3, any kind of immunotherapy for small cell. If I had to choose one space, it would actually be in limited, the Adriatic. The benefit for extensive stage is real, but modest. And of course, we want to be ready and give bite therapy when that actually becomes practical and affordable and reaches us, because I think that's also a game changer. So I'm going to just sneak that in. I'm going to call that the broader immunotherapy. And then lastly, because close to my heart's precision oncology, that's a complete on a one-to-one basis with a patient. The impact of an effective targeted therapy is immense. And we currently have covered EGFR. That's the sensitive ones, not exon 20s. We have ALK with a single option of alectinib, and we have actually 2 options for ROS as of this year. And because I think the fusions are absolute game changers, the next one I want is a RET inhibitor. And then I want all those others on the ESMO guideline, from HER2 and BRAF. There's tons of others we don't have, but you can't get everything you want at once. And if we're looking at population level impact for lung cancer, that's my ranking. So just give it all to me. We'll keep trying.
It's a great wish list. Annie, what do you think?
I have a much more modest but high-reaching, high-bar wish list. I would really love for Health New Zealand to see clinical trials as standard of care. I think it's at the moment, everyone's busy, everyone's under-resourced, and so it's always seen as this nice to have. I think that they are setting groups to try and address this. So I think that's a great direction. I would love for the country to be seen as a single locality so that ethics approval and registration would be more streamlined. We're very good at working together as a country, and I think having decentralized trials will just provide that access to people in smaller regional areas where they can't set up a big study. So I think that's my one big wish list.
No, it's, in some ways quite similar to my wish list. Some of the things that Australia could do a lot better also. And I guess for you both, what needs to change in New Zealand's lung cancer care system? What do you see as the biggest obstacle?
I don't know. I love the people I work with, and I actually think the lung cancer care system has its heart in the right place, and that there's improvements needed everywhere, from resource for diagnostics to access to treatments to the delay in funding treatment. You could start rattling off a big list. But actually the system itself, which has an open door to all patients with lung cancer, I think is a valuable thing. And there is emphasis on research. I agree with Annie that having that entrenched more in every clinic in the country would be great. I actually don't have a major change to the lung cancer care system itself. It's just I want to keep pushing in all the fronts within the model we have. That's what I think.
I think for me is maybe just having a better understanding of who are the people that this system is failing. I'm sure in Australia as well, you have this rising cost of living and people can't actually access their primary health care. These are big sociological challenges that are not limited to lung cancer, not limited to healthcare. And I think for us to make sure that the care is getting to the right people, as Laird said, actually we need to see what our gaps are, and having better understanding of that is important.
Yeah, I think, look, I kind of echo that in Australia, where sometimes it's nice to have access to a $100,000 a year drug, but geez, it would be great if we had a mental health counsellor for our cancers, because I can tell you what would make a bigger difference in the quality of our patients' lives. But I guess, as a myopic Sydney-sider, is there anything we haven't covered in the conversation today I should know about New Zealand or lung cancer in New Zealand?
I think we've covered a lot, so I can't immediately think of any gaps. I'll think of that as soon as we finish the podcast.
I think the TOGA listeners, having heard this podcast, would know more about lung cancer than most New Zealand doctors.
It's been pretty comprehensive, I think, because we've dipped into all sorts of spaces.
Fantastic. That brings us to the end of this episode. Thank you, Laird and Annie, for joining us during that discussion. As always, thanks for listening to TOGA's Conversations in Lung Cancer Research. If you enjoy our show, please rate and review us on Apple Podcasts or Spotify.
Thanks, Alex.
Thanks, Alex.